you very much, Anthony, and I want to thank the regional planners and organizers of this session. It's really an honor and a delight to be here today, and particularly to be here in the month of November, which is Domestic Violence Awareness Month, or in some optimistic circles, Domestic Violence Prevention Month. I am going to be presenting the first part of this two-part, 1-hour discussion, and am focusing particularly on the topic of screening issues and screening for women abuse. And I have to say that violence against women, abuse and trauma is one of the subjects I am most passionate about, and I'm really happy that you're all joining in today and hope that you are able to take something meaningful away from this conversation. So as we get started, I think it would be, be really helpful that we have a common understanding of what we're talking about in this session. And I have to say that women abuse is also known as intimate partner violence, domestic violence, spouse abuse, spousal assault. There are any number of terms, but what they have in common is a sense of one person's exertion of power and control through a set of coercive behaviors on a less powerful partner. So the World Health Organization has actually provided a definition that says intimate partner violence includes acts of physical aggression, psychological abuse, forced intercourse and other forms of sexual coercion, and various controlling behaviors such as isolating a person from family and friends or restricting access to information and assistance. So all too often we tend to think of intimate partner violence, or IPV as it's known in the short form, as physical violence. And it is important to remember these other various forms which women have declared to be even more harmful to them than the physical assaults. So how common a problem is this in Canada? Well, the last General Social Survey indicated that 7% of Canadian women in the previous 5-year experience had experienced physical and or sexual abuse by their current or former partner. And if you remember the definition on the prior slide, this 7% does not include emotional, psychological, and or financial abuse. If we throw those forms of abusive behaviors into the pot, we see that the number of women who've experienced in the previous 5 years such coercion is 18%. And when there is emotional abuse, 25% of women and 19% of men also experience that concurrently with physical violence. So none of these experiences is exclusionary. If you experience physical assault, you are likely also experiencing emotional abuse. Frequently, we know emotional abuse can escalate and result in physical abuse. So at some point over the life course, 1 in 3 women will experience an act of violence or abuse by a current or former partner. And underreporting is a huge and significant issue for all sorts of reasons, including women's sense of shame and embarrassment, not recognizing that the behaviors that they are being subjected to actually are abuse or would be considered abuse by others. We do know that in the General Social Survey of 2004, 7% of women, but also 6% of men indicated that they had experienced an act of abuse by their partner. And this is where it gets really interesting to look at what statistics tell us and what they conceal. So 7% of women and 6% of men would make us think that this may be actually an equally experienced relationship issue. But in fact, if we look at how these incidents are measured, and they are measured using a tool called the conflict tactics scale, you'll see that, in fact, having something thrown at you and being strangled are counted equally as one episode. So to take a more gendered lens to those stats, we see that women, the 7% of women who experience abuse, They're 5 times more likely to have been injured and to require medical attention than men are from acts of IPV. They're 5 times more likely to fear for their life, 5 times more likely to have been strangled, and 3 times more likely to require time off from work to heal from their injuries or from the emotional abuse. And we are talking about patterned behavior. So 65% of women report being assaulted more than once, and more than 25% are victimized more than 10 times. If we look at the experiences of men, we see that men are more likely to experience being slapped, hit, kicked, bitten, or having something thrown at them, and are less likely to experience injury as a result of the abuse. However, I don't want to undermine the fact that there is abuse against men as well as against women, and that men who do experience abuse in the context of their relationship are very hard-pressed to find services to help them deal with that experience. But remember, the predominant victims in these situations are women. If we ask men about their behaviors, we see that 7% of men will report having hurt their partner in the past year, and 16% report ever having hurt their partner. And look at this at the bottom. 93% of both men and women believe that their physicians could be helpful in these situations. I'm going to apologize now for the cold that I'm fighting. I'm going to just take a sip of water. At the very, very abusive end of the continuum of behaviors of intimate partner violence, we come up with homicide or femicide when it's an act committed against a woman. In Ontario, we are very fortunate to have, through the coroner's office, a group called the Domestic Violence Death Review Committee, or DVDRC, which reviews cases of homicide and femicide that have gone through the court system. So once the courts are through with the case, they sit down and examine in close detail, interviewing friends, neighbors, relatives, social services that may have been involved with one or other of the partners to determine what could have been done to prevent this most tragic ending. They have revealed to us what the high-risk factors are in cases of homicide, femicide, and suicide, and have said that in 8 out of 9 cases that they have examined, the murder was both predictable and preventable had we known what to look for. In a U.S. study, 69% of the victims of femicide, so women who were murdered, were also abused prior to their death, and 41% of them were seen in a healthcare setting. And I put this up because it's both alarming and encouraging. It's alarming that there are this number of deaths. 20 women and 3 children were murdered by a current or former partner, and there were also suicides in those cases by the abusive partner. But the encouraging part is that the healthcare system does have an opportunity to recognize what's going on and to provide an intervention that may be helpful in avoiding this kind of outcome. If we pay attention to what the DVDRC has told us are the risk factors, these are Ontario-based risk factors, but they are also replicated in many studies around the world. We see that the number 1 risk factor is actual or pending separation. And we have known that for a long time, that a woman who says she wants to leave or is about to leave or recently leaves an abusive partner is actually at greatest risk at the time of the separation or planning for that separation. So this makes it clear that one of our tasks as service providers is to make sure that women know that this is a high-risk period and not to share their plans with their abusive partner. Not surprisingly, a past history of domestic violence is also a key risk factor. And then the perpetrator's mental state, whether he's depressed, and this is depressed on the basis of what friends and family members report. It's not a clinical diagnosis. It's also very significant, as is from other studies, a perpetrator's unemployment. Not just unemployment, but when he gives up hope of ever finding employment. So you can see how that would link with the depression. And the other key risk factors are up there for you to examine. So clearly this is a complex issue. And there are different ways of trying to make sense of what's going on in abusive relationships. One of those frameworks that we use to think about this issue is a systems view, where we recognize that there is a role for the multiple services and sectors to try and intervene and prevent and protect vulnerable women and children. You'll see that the health sector has a key role to play, but it can't do it on its own. And that's one of the reasons why I like this particular framework, because it makes it clear that it requires a coordinated response across multiple sectors and jurisdictions. Another commonly referred to model is the ecological model, and anyone who has entered smoking cessation programs or thought about stopping smoking may be familiar with this. It looks at various risk and protective factors at across a number of different levels, beginning with the individual right through to society. And it's when the risk factors are outnumbered by the protective factors that we begin to see violence occurring between individuals. So what would a risk factor at the individual level be? Well, it might be an individual who has grown up in an abusive family and who has become immune or inured to violent behavior as a way of resolving conflict. Similarly, a protective factor at that level would be someone who's grown up in a family with healthy, equal relationships. At the relationship level, the protective factors and risk factors might have to do with the way the couple negotiates conflict, whether they do so in a discursive way or whether they do so in a violent manner. And at the societal level, it has to do with our laws and regulations around gun control, for example, that make it more difficult or easier to access weapons that can be used in a violent relationship. This framework, the power and control wheel, may be familiar to you. It was developed in Duluth, Minnesota, by a group of abusive men who, when working with a counselor, were asked to describe the behaviors that they had used to maintain power and exert control over their partners. And it includes both physical, sexual behaviors, as well as such things as using male privilege or hegemonic privilege, using the children to keep a woman in a relationship, threatening that she'll never gain access or custody to them should she leave, as well as blaming her, isolating her, using emotional abuse, intimidation, coercion, and threats, as well as maintaining control over finances. So these are very behavioral in nature and are very individual in focus. So it's the individual's expression of these behaviors that is being examined here. We know that domestic violence impacts health. We know that it can also contribute to other health problems. It can exacerbate mental health problems. It contributes to social isolation. Women who are abused may not be succeeding in the workplace because of not being able to attend work regularly, being distracted when on the job, etc. But we also know that women may respond to the violence in their lives in ways that are not always helpful or healthy for them. They may turn to substances as a way of managing their anxiety, as a way of managing depression. They may be prescribed substances by physicians who do not seek out the cause, for example, of anxiety or sleeplessness or depression, and who seek to prescribe a medication instead of determining the root cause. In terms of physical violence, we know to look for black eyes. That's the very obvious kind of presentation that we first think about, broken bones and black eyes. We may not actually be thinking about internal bleeding. We may not recognize injury during pregnancy, and Patricia's going to talk a little bit more about pregnancy and infant development in a few minutes. But pregnancy is recognized now as a window of change, so that sometimes abuse that has started in the past may stop with pregnancy. It may grow worse with pregnancy, and sometimes abuse just begins when a woman becomes pregnant. Hypothetical explanations for this are that a male partner may feel threatened by the arrival of a new baby, may not want to share his partner's attention, for example. So in addition to those injuries that we looked at, there may be less obvious injuries. There also have domestic violence as an underlying root cause. Everything from headaches to hearing problems, from being hit about the head, or shaken adult syndrome, where a woman may be violently shaken and her actual causes brain trauma, urinary tract infections due to sexual assault, strangulation-based problems in breathing, a host of other issues. As we move down this continuum from the obvious to the less obvious, we also begin to see the symptoms associated with ongoing and enduring stress. Imagine living with conditions of unpredictable terror and ongoing fear, and it's not surprising that victims develop all kinds of stress-related symptoms, or can develop all kinds of stress-related symptoms, including gastrointestinal problems and irritable bowel syndrome, as well as appetite disorders and anorexia, bulimia, hyperventilation, and chronic pain. The list of mental health problems is enormous. In fact, I would just say at any time, any presentation could have as an underlying cause the stress and anxiety and harm that results from living in a problematic and violent relationship. There are other red flags: limited ability to keep medical appointments, a partner who may be overly controlling, and a patient who may appear non-compliant. I do want to caution that partners who appear overprotective are very much Western culturally based, and that we have to recognize that there are different forms of relationships, and in some communities the partner is expected to attend medical appointments. So all of this is leading to our screening question. Should we be asking about domestic violence? Well, women tell us that they don't mind being asked, or that they want to be asked. What they really care about is the way that we ask them. That is more important, and I'm going to emphasize it again later. It's more important than any screening tool we use. This is a cartoon that Sandra Bell Lundy did as part of a series in 2008, where two old friends encounter each other, and the one friend begins to suspect that the old friend is being subjected to abuse, but is very unnerved by it and doesn't know whether to ask about it or not. And says, if she's willing to put up with an abusive relationship, what can I do? I can't make her leave, because it's not really my business. And her third friend says to her, well, if it's not your business, whose business is it? It's all of our business. So let's turn to screening. Screening is still, in 2012, a somewhat contentious issue. There have been a number of systematic reviews and randomized controlled trials to examine the impacts of screening on women and on their health and on their subsequent experience of violence or nonviolence. The evidence from these is somewhat confusing. So in 2003, we were told that there was insufficient evidence to recommend for or against routine screening, but sufficient evidence for case finding, and that all practitioners should maintain a high level or a high index of suspicion and follow up on those situations that cause suspicion. Those findings were replicated and repeated in 2004 in the U.S., but recently updated to include the conclusion that screening could reduce intimate partner violence and improve health. But the studies that we've seen so far have had such significant limitations that we can only make qualified judgments about it. What we do know is that routine screening does not cause any harm. No harm results from it. And I would say that it really is going to depend on what we use as our outcome. Do we really suspect or expect that our asking a woman about her safety in a relationship, about her experiences of being hit or hurt, do we expect that that could lead to improved health, improved quality of life, or be the one thing that actually gets her to re-examine her relationship? And I would argue that it's an important piece of that pie if we look at a systems approach, and it can serve to highlight the importance of this issue for women. So there are a number of different screening tools to use, and I always say that I would just prefer to ask women in a dialogic manner about their experiences, but you do have to develop some comfort with the situation and the issue before you can do that. And so as you do develop that comfort, using a standardized tool can be helpful. So I have just indicated here what some of the most popular and common tools that have been shown to be effective are. So this one is called HIT, Hurts, Insults, Threats, and Screams, and it consists of 4 questions. How often does your partner hurt you physically, insult or talk down to you, threaten you with harm, scream, or curse at you? The WASP is another very common tool that was actually developed for family practice, and in emergency departments was used in a short version. They don't provide a way of scoring it, but it includes 8 questions, which begin a little bit more gently. In general, how would you describe your relationship? With a lot of tension, some tension, or no tension? How do you and your partner work out arguments? Do arguments ever result in you feeling down or bad about yourself? Well, I can tell you right now, after an argument, I almost always feel bad. But you can see it leads a little bit more gently to some questions about fear and actual physical abuse. The PVS, or Partner Violence Screen, is a 3-question tool that was developed particularly for emergency departments, and again, it goes very quickly into the issues of have you been hit, kicked, punched, or otherwise hurt? Do you feel safe? And is there a partner from a previous relationship making you feel unsafe? And I think this is the last one, the Abuse Assessment Screen. Have you ever been emotionally or physically abused by your partner or someone important to you, which could get at experiences of childhood abuse as well? And then question 3 focuses on the pregnancy period, recognizing that the ASS can be used during pregnancy. London Middlesex has introduced the RUX protocol, which doesn't have specific questions to it, but does refer practitioners to ask every female addressed safely to refer and document and educate patients about the issue. And they've developed a mnemonic, ABCDER, that help you use sound principles so that you have the non-judgmental attitude, you believe her, you ask in confidence, you document, you educate her about the health effects, and you respect her choices and her pacing, whatever her choices are. So women have told us a lot about what they would like us to do. They tell us they want to be treated like human beings. They want someone to say, this is not right, you don't deserve this. And they don't want to be shut down. So they don't want those questions, any one of those tools, to be asked as a checklist. They want to be asked by someone who wants to hear their response. They remind us that it's important to ask in confidence with no other members of the family present and not to use family members as interpreters. And they want us to maintain a non-judgmental attitude. And I particularly like this last quote. It is never so much about the words you use, but the motives behind them. If the questions are asked to support a client or patient towards their goals and help them be safer, then that comes across. So if you would care to learn more than we can provide in this hour, we have developed an interactive curriculum. It's available free of charge. There are CME credits attached to it, and it's available at www.dveducation.ca. It is evidence-based and research-informed. And I'm now going to very quickly scoot out of this seat and turn it over to my colleague, Patricia.